Hello, everybody. Thank you for joining us. Today, I'll be joined by Dr. Laul. Myself, I'm practicing at Mount Sinai Morningside, which is a hospital in Manhattan, New York. Very heavy disease population, a lot of glaucoma, a lot of diabetics. So we tend to do a lot of imaging in our practice. And Dr. Laul, he's an associate clinical professor at SUNY College of Optometry here in Manhattan as well. He is also in the glaucoma clinic at the SUNY College of Optometry, so he sees a ton of glaucoma as well. Together, we'll be talking about the practical approach to the glaucoma suspect. First of all, what is a glaucoma suspect? The Academy defines a glaucoma suspect as an individual with clinical findings and/or a constellation of risk factors that indicate an increased likelihood of developing glaucoma. So these risk factors, there's a whole bunch of them. The big ones are going to be increased cupping, cup asymmetry, RNFL defects that you can see clinically, disc hemorrhages, IOP, thin packs, age, visual field defects that are consistent with glaucoma, so that's an important thing to keep in mind. And then OCT, both of the RNFL, optic nerve, and the macula, which are going to be consistent with glaucoma defects. Family history, African descent or Hispanic race, and then things like pseudoexfoliation, pigment dispersion, and myopia. These first few, the cupping, IOP, PACS, age, and visual field, these were really important risk factors in the OATS trial, and this is what they incorporated into the OATS calculator for those of you that use that. So the way I think about our patients is we have a whole bunch of patients which we know definitely do not have glaucoma. So these are patients that are healthy, normal pressure, no significant cupping, no RNFL defects. And then we have a much smaller group of patients who definitely have glaucoma. These are your 0.9 cups with 30 IOP. They have tremendous visual field defects, tremendous OCT defects. So those are easy to really tell. And then we have this sort of overlap of patients where we're not so sure what's going on. So these are your glaucoma suspects, your ocular hypertensive, anomalous discs. And these are the ones that sometimes sort of keep us up at night trying to figure out if we're doing the right thing, whether we treat or we don't treat. And sometimes it's really hard to tell which way to go, and it's important to have a really systematic way of thinking about these. So for those of us who treat and manage and bill for glaucoma patients, this is something that we've seen pretty often. So low-risk glaucoma suspects and high-risk glaucoma suspects, this is really based on sort of Medicare, CMS rules, and this is how we bill things. So anything with 2 or less risk factors is going to be a low risk, and anything 3 or more is a high risk. Now, the important thing is that risk factors only include these things here. So it's not that long list that I was talking about before. And this is a pretty good way when you're talking about just billing for these patients and using the proper ICD-10 code. But, speaking with Anu, even though we're not in the same clinic, we don't see patients together, we're not even in the same building seeing patients, but we've talked in hours and hours about glaucoma and glaucoma suspects. And we actually have a lot in common in how we think about these patients, and our philosophy is very similar. So we'll be going over something called the Epshtein and Laul paradigm, which is nothing official. We haven't published it. It's not peer-reviewed yet, at least. Maybe in a few months it will be. Who knows? And the way we like to think about these patients that come to us and need glaucoma evaluations, or who we deem need a glaucoma evaluation just because we've been the first person that sees them, is we have low-risk patients. So these are patients that have some risks, but their OCT and visual field is unremarkable. So these are patients with physiological cupping, or maybe their pressure is a little bit high. Then we have patients that are medium risk. So these are patients with some risk factors and borderline OCT visual field findings. And then we have high risk or inconclusive glaucoma patients. So these are the patients that have significant risk factors, and maybe they have discordant visual field and OCT findings, or maybe they have something else that's confounding your test results, like high myopia or other comorbidities. So it's actually pretty hard to tell if these patients have glaucoma. And then, of course, we have the patients with definitive glaucoma. Either you have documented progression, or you have corresponding visual field OCT defects on these patients. So the ones that have an inferior notch, inferior RNFL OCT thinning, corresponding GCA thinning, and a visual field defect, those are easy to tell. And then, of course, you have your non-glaucomatous optic neuropathy patients, which a lot of times you might find while you're checking for a glaucoma. What do we do with glaucoma suspects? The big thing is you have to get a full workup on them. So for myself, I like to get fundus photos on the day of their dilation. Then I have them come back for OCT, visual fields, pachymetry, gonio, and then of course an IOP check every time I see them. Part of a glaucoma workup is OCTs and visual fields. They compare the patient against the average patient. So the Humphrey visual field, the Cirrus OCT, they have these normative databases that will compare a snapshot of your patient to the average patient. Things like fundus photos, OCTs, and visual fields, they also can compare your patient currently to what your patient was in the past. So let's say I take a fundus photo today. That's my baseline for the patient's optic nerve and cup going forward for years. So every year when I look at that patient's dilated exam, or if I'm doing it every 6 months, it lets me compare to what it was in the past. Same thing with OCT and visual fields. Not only are you comparing to a normative database, you're also comparing it for progression. So imaging helps us both with diagnosis and the detection of progression. So using it sort of in a twofold way. And then of course, once you do your glaucoma workup, it's important you have to follow up your patients and repeat your testing as necessary based on the risk. So this is just a little workflow that we have. Assuming this is a patient I've seen for the first time on their initial visit, I'm dilating that patient probably 95% of the time, at least in my practice. I also get an IOP check. If I deem the patient a glaucoma suspect, then I'll also order a fundus photo to have a baseline of the patient's nerve. And then I usually follow up with the patient in about 6 weeks for an OCT, visual field, PACS, gonio, and another IOP check. I usually like to do it within 6 weeks. The reason why is because one, it lets the patient know that there's something I'm concerned about. And also, patients tend not to be lost to follow-up if you do it relatively quickly. So sometimes patients will show up in a week, sometimes in 6 weeks. It depends on the patient, and also sort of depends on my schedule. Everyone's schedule is a little bit different, where you might have availability tomorrow, or you might be booked out for a month or two. So you have to sort of work around that.
When it comes to judging risk, I think that we've all been in a situation like this where I looked at this patient and their eye pressures are maybe high teens. The nerves look a little bit suspicious, but not very suspicious, and they don't have any family history per the patient's history as part of your examination. And then when you see this patient back a few weeks later and you realize after taking an OCT that there's a huge wedge defect. So it is one of these things where it's really tough for you to assess risk really without having the baseline testing. So anytime that I feel like a patient needs that baseline testing, why wait? So I usually get it done just like you do between the first 4 to 8 weeks of my initial visit.
Yeah, that's a good point, because you might have a patient who you think is low risk, and they might have, let's say, 19 pressure, moderate cupping, then they come back and you notice their pressure is much higher. They have 25 pressure. And then
what if their PACs are, 470? It's one of those things where that 19 now it worries me a little more than it did before. So, without doing the testing, can't really judge. So I think it's worthwhile to get it done early.
Yeah, exactly. Once you have them come back for your first follow-up, which is going to be your second total visit, then you sort of stratify them based on risk, like we were talking about. Now, the patients who are very low risk, these are usually the patients who maybe have 1 or 2 risk factors. Everything looks great, meaning the IOP is still normal tensive, their PACs are average, their visual field and OCT is unremarkable. Sometimes I'll see them back in about 11 months, and that'll be their regular yearly checkup, and I'll repeat the testing. For the medium risk patients, I'll see them back maybe 2 to 4 months. I'll repeat the visual field, get another IOP check. The high risk patients, maybe about 1 to 4 weeks, again, repeat the visual field and get another IOP check. At this point, I might start considering treatment. So especially patients like, let's say, a high myope where the visual field might have some defects, the OCT, because of the anomalous nerve, might not be so reliable, so it might be hard to follow these patients. I might start on prophylactic treatment if their eye pressure is a little bit elevated, especially if they have a family history of blindness from glaucoma in the family. The patients with definite glaucoma, you could initiate treatment on that second visit. Ideally, I like to have 3 IOP checks for patients, and hopefully you can do maybe some in the morning, some in the afternoon or the evening to try to get some sort of diurnal makeshift curve for these patients. But of course, at some point you want to initiate therapy, whether that's medical therapy or you need an LPI if they're narrow angles, or SLT. The non-glaucomatous patients, of course, you need to do appropriate evaluation there.
The thing about glaucoma, and I love this chart, is that the beauty of it is that there is no clear-cut, cookie-cutter approach to glaucoma. And I think we all do something very similar to this. But I definitely agree. I think the importance of getting a few more IOP checks before starting treatment is absolutely imperative. And then, getting some of that additional testing done at 1 or 2 visits, really just to solidify your diagnosis and again, ensuring that you're not missing something else. So absolutely, I think this is great. Yeah.
So I think let's go through a few cases. This patient is a 47-year-old white male, presents for his diabetic exam. He has no complaints. He has great vision. His IOP is a little bit high. And of course, I dilate him. First thing we notice is his cups are a little bit larger, maybe about 0.6 in the right eye, a 5.5 in the left eye. And remember, he is diabetic, so he does have some diabetic changes, some mild NPDR. Of course, as you can see, I did take a fundus photo on that first visit, like I do with all my glaucoma suspects. And of course, I have the conversation with him. We need to see you back. We need more testing. So he comes back in about a month, and the family history, he went around and asked his whole family, and he came back and he told me his stepsister has glaucoma. And I'm like, that's great. I'm glad you asked everyone in your family, but that doesn't really do much for us. Not too helpful for me. His pressure, again, a little bit elevated. His PACs, a little bit on the thinner side. His gonio is open. So looking at his OCT, of course, the quadrants is the first thing I look at. All green, white, making it super normal. It's a little bit thicker. And then the deviation map looks pretty good as well. And we move on to the visual field. Again, visual field, maybe a little bit of defects in the right eye, but overall for a first visual field, pretty clean. These little edge defects probably from the trial lens. I don't think it's too much to worry about. Now, when we look at everything together, especially when you're looking at that quadrant, there is a little bit of asymmetry, the 122 versus a 135 superiorly, but it's not really correlating to much on the visual field. There's no really inferior defects that would correlate to. So overall, this patient is still a glaucoma suspect, a little bit of elevated IOP, but I don't see any definite signs of glaucoma. I think at this point, I say the patient's a glaucoma suspect, come back in about 3 months, we'll repeat the visual field and check the IOP again. Any thoughts?
Yeah, no, I think I'm in the same boat, as you are. As I'm looking at the T-SNP curve here, so you can see that superior temporal areas, things are, they overlap quite a bit. And then in the nasal areas, they may not overlap as much. And then they tend to overlap again, in that inferior and temporal portions. So, those areas of discordance between the right eye and the left eye, nasally, we don't get glaucoma on the nasal aspect of the optic nerve. So again, when it comes to risk, I think that you're right. I think this patient's relatively low, but I think it's worthwhile to actually watch this patient. Pressures are sort of at that just above the normal range, larger CD ratios. So I do think it's worthwhile to watch this patient. And the other thing is that it is worthwhile to also get proper baseline testing. Because, if this patient is going to be your patient, he's 47 years old, it's going to be your patient for life, having 2 visual fields and a couple of OCTs, back in 2019 or 2020, and now you're seeing this patient who is now 57, so 10 years from now, it's always good to, have some of that data. And I have an example of that coming up where having that longitudinal data is actually quite helpful. So, yeah, I'm there with you.
Yep, the more data we have, the better. So this patient came back, and this is about 4 months after our initial presentation. And this is actually a 24-2C. So this is a newer Humphrey visual field protocol. I've started using this on all my patients now. I don't do the normal 24-2 anymore. This is fantastic because it's the regular 24-2 protocol, but then it has 10 macular points. So we were talking about how important the macula is in all grades of glaucoma. Well, this is really aligning what we do clinically with what the research is showing. So I've been using this quite a bit. The IOP, again, slightly elevated, but I'm not really seeing too much on the deviation maps on the visual field. Maybe some mild non-specific defects here, and this might be just a little bit of an edge defect. Looking at everything together, again, I don't have any glaring signs of glaucoma here. The good thing is that his pressure, now we have 3 visits, and it's been pretty stable. There's no huge spikes, no huge depression, so that makes me pretty happy that I think we're accurately measuring his IOP at least. PACs are a little bit thinner. He does have moderate cupping, so this is not something we want to forget about. So at this point, still a glaucoma suspect. Want him back in 6 months. We're going to repeat his testing, and the more data we have, of course, the better our decision-making process is going to be. So this patient, a little more interesting than our other glaucoma suspects. So this is a 65-year-old black male, comes in complaining of near blur, ends up having great vision with the refraction. IOP is borderline, dilate him, and he has moderate cupping. But the big thing is he has this little disc heme. At this point, I was working with fourth-year students supervising, and unfortunately, the student did miss it, but luckily I caught it without the fundus photo. So we know that on the OATS study, 83% of these disc hemes were missed clinically. And these are glaucoma specialists that knew they were in a research study, so they were really trying really well to examine their patients. So they're missing the huge bulk of their disc hemes without fundus photos. It's like, what hope do us regular docs have,
Again, it's another reason why we really need to continue to take disc photos. I think disc photos are so important.
Yeah, I think because OCT and visual field has gotten so good that fundus photos have sort of fallen out of favor, but I get them on all my glaucoma suspects, or at least I try.
Yeah, it's one of those things where with my glaucoma micro-credential students at the college, one of the first lectures that I gave them really dissected the optic nerve. Because really when it comes to glaucoma, it is a disease of the optic nerve, and you really have to look at the optic nerve. So getting good at analyzing the optic nerve is imperative. The more that you tend to do so, the more likely you are to pick up some of these things like disc hemorrhages and not. Unfortunately, as we're going through and doing our examinations, we've been so ingrained to think about CD ratios that we only look at that center portion of the optic nerve, and we sometimes don't branch out. And sometimes disc seams are right at the edge like that, or sometimes even just slightly outside of the cup or the disc. And if you don't kind of move your eyes out that way, you'll absolutely miss it. So, great pickup.
Thank
I can
you.
see that you're better than students.
That's good. I mean, this heme, you look at it, it's really almost camouflaged with those blood vessels right there. It's really tough to pick up.
Yeah, that's a really tough one.
So, of course, this is a glaucoma suspect, and they're coming back for the full workup. About 4 weeks later, this patient shows up, pressure 24-21. So remember, the right eye is the one with the disc heme, so that's the one we're really worried about. PAX, maybe thin average, but nothing too thin. Gonio was open. And again, first thing I look at is the quadrants. Everything looks fantastic in terms of colors, but look at that huge asymmetry. And the asymmetry, 114 in the right eye versus 156 in the left eye, that really corresponds really well with the disc heme that we saw and the bigger cup in the right eye. And that, of course, also corresponds with our deviation map, with our T-SNIT asymmetry, and our average RNFL thickness asymmetry. So this is what we were talking about before, where even though the quadrant is green, you can clearly see that RNFL defect, even though you might not see an RNFL defect clinically, but that's right where that disc heme is. So this is why I love the Zeiss deviation map, that without that really sort of red and yellow highlighted, it might be a little bit tough for you to tell, unless you're really looking at these asymmetries between the two eyes.
Yeah, it's kind of interesting. Now, this is where we differ a little, because I don't spend a lot of time looking at the quadrants. The deviation map is the heat map deviation map, and then looking at the symmetry of the T-SNIT curve, because you can clearly see as you circled it there, that inferior section, there's a big difference between the right and the left eye. That solid line, which is that right eye, there's a huge dip or deficit, which requires investigation. So yeah, great pickup.
And of course, we get our visual field. And the visual field corresponds pretty well. So you have that superior nasal step correlating with our thinning on the RNFL. That's really picked up pretty well the deviation map and our T-SNIT curve. And of course, with that disc heme we saw. So with this patient, I think we can say this is definite glaucoma. We have correlating data there. Ideally, I always like to get 3 IOP checks. So I actually had this patient come back in about 1 to 3 weeks to get another IOP check, but I told him, look, you're coming back, but you're starting treatment no matter what. So he was already set up for it. And I think his IOP was about the same. This sort of lets me know what his Tmax is and how to develop his target IOP.
And I think you actually bring up a good point. Throwing this all at a patient at once can be sometimes overwhelming. So what I do like to do is I like to show the patients the data, look at the findings here that I have, talk to them about their pressures and their visual fields. And then I say, really our next steps is some sort of intervention, whether it be eye drops or whether it be laser, some sort of intervention And, I say, well, why don't we get one more eye pressure check, and it lets them ruminate a little bit, it lets them think about, their condition a little bit, so that when they do come back in, they're already expecting some sort of treatment, whether it be drops or an SLT. So, we're at a point where the patient has really come to terms with it. So sometimes it can be very overwhelming, all of this at one single visit. And I like the fact that you kind of split this up, because that's exactly what I do.
Yeah, that's a good point. From the patient's point, it's sort of the
Yeah.
psychological aspect of it. It is a lot of information for them. And this is, again, a lifelong disease. This guy's relatively young, 65 years old.
Sure.
So let's say he has 20, 30, 40 years of treatment ahead of him.
The other thing to consider is that, when you hear about things like glaucoma, or if you Google things like glaucoma, it is a blinding condition, and people automatically, think that they're going to go blind. So, I think that, after you make the diagnosis, I do spend a lot of time talking to my patients saying, hey, you know what? This condition is treatable. We can treat this, and we can make sure we can do our best to ensure that you have good, functional, useful vision for the rest of your life. I'm definitely going to work with you. You need to work with me. So when we do start putting you on some eye drops or medications, I do need you to come back in for your follow-ups. I do need you to take your medications as prescribed, and together, we can make sure that we maintain your vision. And I think that's that team approach. So me and the patient, that team approach tends to increase compliance, tends to increase patients coming back and being more fruitful with their medications. So,
yeah, that's a great point. So, once a patient has glaucoma, we have to sort of grade it. And the Academy and American Glaucoma Society and sort of ICD-10 way of grading it is going to be here on your left side, where they have mild, moderate, advanced. It's a little bit different than what I think we do clinically. I use the Hodat-Parrish-Anderson criteria a lot, where it's also early, moderate, and severe, but this is based on more on the mean deviation of your visual field and the sensitivity of specific areas on the visual field. The criteria on the left side, this makes more sense, of course, for billing, that's what you got to do. But in terms of visual function, so mild or early patients, they have no visual field defects. Moderate patients have defects only in one hemifield, and then advanced, of course, is anything worse than that. So it does make sense in one way, but then a lot of our landmark studies, they didn't really use something close to that. They used something more similar to maybe the Hodat-Parrish-Anderson criteria, or there's other glaucoma severity score scales out there.
Yeah, absolutely. So, I think it's one of those things that, from an academic standpoint, this is what we teach our students. We talk about the Hodat-Parrish-Anderson grading systems. And I think it is one of the things that when it comes to classifying glaucoma, from an academic standpoint, that's really what our students know, really what our students learn. But when they do get to me in their fourth year of clinic and they're in my glaucoma service, I usually sort of show them the Academy of Ophthalmology and the AGS grading scale, because as you can see, it actually does talk about the ICD-10 codes. And for most students, and I think for most practitioners, it's an easier approach, because it's just a couple of bullet points. So for mild, you have the optic nerve abnormalities, but with no functional vision loss on a visual field test. For the moderate, you have the optic nerve abnormalities, but you also have visual field defects in one, hemifield that's not within that central 5 degrees of fixation. And then the severe is within central 5 degrees of fixation, or loss in both hemifields. So from a conceptual standpoint, I think for a practicing clinician, that might be an easier grading system. But when we do all our studies, and from an academic standpoint, the Hodat-Parrish-Anderson is probably the way to go. That little sheet that you have, I print that off and I keep it in the clinic, because as you can see on the bottom, it also has the risk factors for open-angle glaucoma suspect. And just like you mentioned it, less than 2, low risk, greater than or equal to 3, high risk. So again, it's a good visual on your busy clinic.
So what do we follow up our glaucoma patients? And that really depends, are they stable and what severity of disease they have. But even though we have these guidelines from the AOA, the big thing to know is that they need a DFE, they need an OCT, they need a visual field, they need gonioscopy at least once a year. I think that's for all our glaucoma patients, and everything else there, you really got to do on a case-by-case basis. And then, of course, once you have a glaucoma diagnosis, or if you have a glaucoma suspect and you're monitoring them for a long period of time, you're checking for progression. So, of course, there's different types of progression. You can have a deepening or worsening of a defect, whether it's on OCT or visual field. You can have a widening of that defect, or you just have a new defect in a different area or in another eye. And then you need to always consider age-related changes, because as we get older, we do lose some axons, we do lose sensitivity on our visual field. And that's always very, very important when we're looking at progression. We're looking just at raw data ourselves. So you got to remember what is normal change. And then we need to consider variability that the instruments have when you take measurements. The glaucoma disease has variability. And of course, anyone that's done more than one visual field on a patient knows the significant variability of our perimetry testing in patients. Luckily, Zeiss created this guided progression analysis, which is available on both the Zeiss Series OCT and on the Humphrey perimeter, which it evaluates data in the context of variability. So it provides objective interpretation of progression. Because if you're looking at just at raw data, you might have a hard time figuring out, is this true progression or it's just variability based on the instrument or the patient. This Zeiss GPA data, it helps guide our management. It helps us answer questions like, is the patient's glaucoma worsening? If it is worsening, how quickly? Is it a fast progressor or a slow progressor? So it's important that if you have something like a fast progressor where you're losing 2 decibels of sensitivity on your visual field per year, in 10 years, you could go from pre-parametric glaucoma to advanced loss with significant effects on your vision quality. Whereas someone who's progressing very slowly, especially if they're a 90-year-old, 95-year-old patient with a shorter life expectancy, you might not need to intervene. It's going to help us sort of figure out, do we need to change our treatment? Because this GPA analysis can also extrapolate data. It sort of gives you this nice slope, which I think we have a few slides of that coming up, and it'll help you predict what the visual field parameters will be in the future.
Awesome, Dan. Thank you so much. So you actually bring up a really good point. Progression, I think that's the real value of the OCT, because we know that glaucoma is a progressive condition. So I think the big benefit is looking at change over time. So the examples that you showed were done in a relatively short period of time. We're looking at this event analysis. So let's have longitudinal analysis. Let's look to see if you have a patient who's been under your care for a long period of time. And I can say this is a great case that I have where the true value of that progression analysis really shines through. So, I started at SUNY in 2016, and we had a patient that I've acquired through the glaucoma service who's been a patient in the glaucoma service for a number of years. So to give you an idea of this patient, she's a 63-year-old Hispanic female back in 2016, and she does have a history of narrow angles. As you can see, she underwent successful LPI procedures, 2006 in the right eye and in 2007 here in the left. Prior to the LPI, this patient's eye pressures were 27 in the right, 26 in the left. As you would expect, a patient who does have narrow angles, this patient is hyperopic. So most of our narrow angle patients are hyperopic, but not severely. Her examination, setup examination are as follows. And as you can see, moderate anterior chamber, patent LPIs, 3 o'clock on the right-hand side, 2 o'clock here on the left. Very mild early cataracts. And as you saw from the patient's visual acuity, this patient is 20/20. So she's just coming on in for her routine follow-up. We know that this patient actually does have these larger cup to disc ratios. And these are her fundus photographs taken in our primary care clinic. As you look at these fundus photographs, as you can see, this patient's vertical cup to disc ratio is in the ballpark of around 6.5, 7. Looking at the rim tissue, they look relatively symmetrical, maybe a little bit thinner inferiorly as opposed to superiorly, but for the most part, the rim tissue looks pretty good. I don't see any obvious hemorrhages or nerve fiber layer dropout, but of course, this patient has been followed in our clinic for a while. She does have a history of narrow angles with that higher eye pressure, but as we've been seeing, her pressures have been pretty good. Pachymetries are just slightly lower than average. And since that LPI procedure, her pressures have been, or they hovered around anywhere from 19 to 21. There's no evidence of PAS or chronic angle closure, in this particular case. But as we mentioned before, having data is quite helpful. So this is her OCT taken in 2016. So as I mentioned before, in terms of the way I look at that OCT is I look at the thickness maps. And looking at the thickness maps here, it gives you an idea of, are there particular areas that are slightly thinner compared to the other? And this is an image of the right eye. This is an image of the left. And I can kind of see that, maybe the left eye is not as robust as compared to the right. The average thicknesses are 97 in the right, 84 in the left, with a pretty good symmetry. When it comes to flagging on that deviation map, in the right eye, nothing is really flagged for the most part. The left eye, still looking pretty good. Could this be a possible flag? I think it is something to keep a good watch on. As I mentioned before, and I think as you brought up the good point, is that, this actually dips outside of that, sample circle. So it may not show up on that T-SNP curve, but looking at this total deviation map, I think it's worthwhile to kind of look outside of the sample circle because it gives you a lot of insight. The other things that I tend to look at is I do look at that circular tomogram because this is the circular tomogram that makes that T-SNP curve. And if there's areas of traction or if there's an impending PVD, that lets you know that this T-SNP curve data might not be as accurate and you may want to recheck that. Since you mentioned the quadrants, this patient's quadrants and clock hours actually look quite good. When I look at that T-SNP curve, it looks like to me that that left eye in some areas are slightly thin as compared to the right. Obviously, we also do a ganglion cell analysis. This is the ganglion cell on this patient. And again, for the most part, the sectors look quite good. I think it's worthwhile to look at areas where you would expect glaucomatous damage. But again, at this point, the patient already had her LPIs, pressures of 21. For the most part, the OCTs are looking pretty good at this visit in 2016. So I think it's worthwhile for us to carry on and follow her. I was not at a stage where I figured that this would be worthwhile to start a patient on medications at this point, because for the most part, things were looking relatively robust. Obviously, we take visual fields as well. Luckily, she's a good visual field test taker. And as you can see, very clear visual fields. I don't think anybody would look at this visual field and say, hey, this patient has glaucoma. This visual field was actually taken in early 2017. So when I saw her, it was late 2016, and we had her back in a month to get that visual field taken just due to logistics issues. So let's go ahead and fast forward to 2019. So I saw her actually late 2019. So as we look at this visual field, again, for the most part, things are looking relatively good. I really don't see much of a difference. Is there a slight decrease in the mean deviation as compared to that previous visual field? Sure, but she went from 63 to now 66. She does have the earliest cataracts. Again, nothing on this visual field screams out to me that this patient has glaucoma. Let's go ahead and look at that OCT. So this is the OCT that was taken in 2019, so late 2019. When it comes to the average thicknesses, I'm looking at this 89 in the right-hand side, 85 in the left. And you can see that maybe the symmetry has changed slightly as compared to previous. But again, I look at these heat maps, those thickness maps, and looking to myself, has anything changed? Again, as I look for glaucoma, I'm looking at these superior and inferior temporal wedges to see if anything shows up. And as you can see here, it looks like there might be a little wedge which was picked up right here on that deviation map. That's why I think the deviation map is so important. When you kind of look at this area on that T-SNP curve, yeah, it actually shows up here as well. So that right-hand side, it's actually looking a little thinner as compared to what it did previously. But nothing has showed up on those quadrants. And I think we mentioned that if there's a really small defect, it might get missed in a quadrant. So it is so imperative to actually look at that deviation map and look at that T-SNP curve as well. You don't want to look at anything in isolation. As we look at that ganglion cell analysis, again, for the most part, it looks pretty good. You can see that the sectors are relatively normal, so I think we're in good shape there. Has this area gotten worse? Yeah, you know what? Maybe it has. Does it correspond to this area? Quite possibly. This area over here on the left-hand side, That might have gotten worse, but I don't think it changed much. I think it might have changed just a little bit. But again, we don't look at things in isolation, right? So as I always mention, you want to compare and contrast. Why bother taking an old visual field or an old OCT if you're not going to look at it? You're not going to compare it to the OCT and the visual field that you have now. So of course, that's exactly what we did. So on your screen here, what you see is that on that left-hand side, that's the 2019 data. On that right-hand side, that's the 2016. And sure enough, you can actually see that difference, right? So things have absolutely changed. You know, the deviation map did pick up that difference between 2016 and 2019. So in that 3-year period, there is a little bit of a difference. And absolutely, that picks it up right there. Why don't we go ahead and have a look at that ganglion cell analysis as well? So the same idea, 2019 on your left-hand side, 2016 on your right. You can see that that nerve, that ganglion cell bundle, that macular bundle looks a little more robust back in 2016. It's a little bit thinner now as opposed to the 2016 data, and absolutely this area has increased. So that being said, it is one of those things where, you know what, things are starting to match up. You know, I'm beginning to think that, is this patient progressing? Does this patient have glaucoma? Is 21 not a good eye pressure for this patient? Do I need to intervene? As Dr. Epshtein mentioned, you know, looking at that progression analysis, looking at that GPA, that's really the bread and butter of glaucoma. I think that that's really the most worthwhile example. So this is a static printout that you can print out on your OCT. And as you can see, we've been following this patient since 2010. So all the way from 2010 to 2019. You know, again, I'm going to start at the top and we're going to kind of move through it. So the baseline testing, so that was the first test here done in 2010. This is the one here done in 2011. You can actually even see a difference between the first two baseline tests. That, you know what, it's not as robust in 2011 as compared to what it was in 2010. And as you move along here, particularly that inferior area, we do tend to see that, hey, you know what, I think we're getting a worsening of an inferior wedge defect. Another way to look at this data is by that deviation map, and you can see that, hey, in this particular spot, we are getting a worsening of that inferior thickness. And I think it's worthwhile to note that in terms of probable loss, the OCT will tell you in yellow that this patient is having probable loss. So you want to watch that area a little more closely. Once you start getting into the reds, that's where we start getting that likely loss. So it's telling you here that, hey, things are changing, and it's a statistically significant change. So sure enough, when you look at the parameters, the actual raw data itself, you're right, that quadrant has changed. So Dan, as you look at those quadrants, this quadrant has changed. Inferiorly, we started at about a 138 microns. We're all the way now down to about 102, and that's a statistically significant difference. The average thickness have also changed as well. So from 101 all the way down to 89. So that is a statistical significance. So there is progression in this case, even though the visual fields actually looked pretty normal in 2019 and pretty normal in previous. Let's move over to the other eye. And similarly, we can see that both inferiorly and superiorly, we are noticing changes. We're noticing thinning of that superior and inferior nerve fiber bundles, which are flagged on that deviation map. So although when I was looking, comparing the 2016 OCT to the 2019 OCT, I didn't really notice a change on the left-hand side, having this longitudinal data over time has really showed me that there is change. And not only inferiorly, but superiorly as well. There is a statistically significant in both quadrants, the inferior and superior quadrants, which is leading us for a average thickness change. So if you can imagine, I was more concerned early on in 2016 of the left eye because the left eye looked a little thinner to me as compared to the right eye. In this case, you know, that right eye has definitely progressed, but, you know, we can't really forget about this left eye because I definitely see progression there. The visual fields, luckily, on this patient has remained relatively stable, and this is an example of the GPA analysis of the visual fields. You know, it's taking that visual field index, the VFI value, and looking at change over time. And this person's slopes are actually pretty good. I mean, it's pretty linear. We're not having that downward slope. We're not having that negative slope. It's actually looking pretty linear. So luckily for this patient, we're not seeing that significant loss in terms of visual function. When you look at this data down here, as you may recall, what this data is telling you is that if there's a greater than 5% deviation as compared to previous, it will show you as a triangle. If there's a greater than 5% deviation on 2 consecutive visual fields, you'll have that half colored in triangle. And if there is a greater than 5% deviation on 3 consecutive visual fields, you'll see that full colored in triangle. So, that's the key when you're reading this type of analysis. One thing that we have at the college that I tend to use quite often is form. And this is just another way to digest that data. So on a single screen, I have every single thing that I just showed you. So this is an example of the right eye. So again, looking at that visual field index, I can see that slope, and in this case, we're really not seeing much of a change. This is giving me both the visual field index, but also the mean deviation. And I can change this to look at the superior half or the inferior half. In this case, I'm looking at both, but you can dissect that data out should you choose to do so. The other thing here is that, as you can see, that average RNFL thickness has been changing over time. So taking this patient all the way back to 2010, you can see that this first little spot here was a likely decrease, right? So a likely progression. And as we move on, these spots are in red, telling us that this is probable progression. This is progression that is, that is happening. The other thing that's kind of nice is that you can actually look at those T-SNP curves. You can actually click on here to give you a progression analysis of the T-SNP curves or a deviation. Now, once you have a lot of data, the deviation map is really not that helpful because the deviation map is just showing you their data as compared to the normative database. But when you have numerous OCTs, you want to compare your patient to your own patient. So you want to compare them to themselves. So the progression analysis is actually very, very useful. So I reuse this all the time. And again, you can actually split this up looking at superiorly quadrant only or inferior quadrant only, depending on how you like to consume the data. One thing that you may have noticed is that the layout on this curve is an Epshtein curve. So we actually change things around. So the T-SNP curve is what you're most used to looking at. But we know from a lot of our most recent studies in the past 10 years that glaucoma tends to affect, that superior, inferior, and in the temporal region, not so much the nasal region. So why not align that curve so that that superior, temporal, and inferior regions are smack dab in the center of your screen, so you're looking right in that middle to see where that data lies. And then lastly, this will give you all of the visual fields and all of the thickness analysis over time. If you click on this button here on that top, this will change it to the deviation map instead. So instead, you'll see, instead of the gray scales, you'll see those little triangles on where a patient is losing data. And instead of looking at a heat map, you're going to see a deviation map down here. So again, depends on how you want to consume that data. So looking here at that right eye, we can obviously see that there is progression pretty close to about 2 microns per year. So it is a significant change. And obviously, as we compare the baseline to the most recent, so the most recent is the current, which is the blue line, we can absolutely see that inferiorly things have changed significantly. As we move on over to the other eye, so this is the left-hand side, again, our visual field is actually pretty stable. In terms of the analysis here, the progression rate is actually pretty close to 0. So the good news here is, things haven't decreased significantly on that visual field. However, we are seeing an average thickness of about 1.6 microns per year. So there is a significant decrease since 2010. And again, you can consume that data how you like. So really what I want to show you now is this patient's IOPs. So the fact of the matter is that since this patient had that LPI, the patient's pressures went down from 27, 28, all the way down to around 21, 22, maybe 19 here and there. And really what this lesson that I have on this particular case is that a lot of us, when we see our patients and we have patients who have narrow angles, we have the LPIs done, we have OCTs that look pretty good, things are in the green, you don't want to stop following these patients, because I think this is an example of a patient where, having those high eye pressures back in, the early 2000s, might have elicited some of this apoptotic mechanism in glaucoma that left this person susceptible, that a pressure of 21 is not acceptable for this patient. We had to bring those pressures down. So in this case, we did start this patient on medications. My target pressure for this patient is 15 or below, and you can see in most cases she ended up 15 or below. A couple of times she kind of fell off here, and it might have been that she didn't take her drops for a couple of days, or she ran out of drops. But I think a big lesson for me in this particular case was the fact that having that longitudinal data really solidified that this patient is indeed worsening. And at this point, I think it's worthwhile to enter.
I think that's a lot of great points you bring up. Looking at our patients in sort of a snapshot view is great for our first initial steps of how to manage these patients. But going forward, we're collecting so much data on them that you really got to look at everything. And just like you showed, sometimes us evaluating the patient's OCTs, just eyeballing everything isn't good enough, that we really need some sort of statistical analysis. That's where these instruments, especially software like Size4 the Glaucoma Workplace, really helps us out quite a bit. And the big thing is you're not making those huge slides like I did where you have a million things on it. It looks terrible there. It's really nice and organized for you. And it's really good. You just change your baselines really quickly as well. So for example, you could change the baselines after the LPI, or if the patient had cataract surgery or a glaucoma procedure, you could change it that your new baseline is after the procedure. Because of course, if you're comparing the patient to the patient before glaucoma surgery, you're definitely going to have some sort of progression. But afterwards, hopefully things end up being pretty stable.
Exactly. So in this particular patient, as you can see, that we started medications around 2017. So you're absolutely right. We can actually re-baseline this patient. And in Size4, I kind of cut off that top area, but there's a button that you can click on adding drops. And you can put the date on when you started the eye drop, and that would actually tell you where the drops were, and then you can reassess this area. So since starting the drops, have things been pretty stable? So this allows me to check that since I started this patient on eye drops, has the patient progressed? So that's a very, very good point.
I think you brought up a lot of great points, and there's a lot of information to really dissect with all our glaucoma patients and glaucoma suspect patients. So I think the big thing is having that practical approach to the glaucoma suspect. We talked a lot about glaucoma suspects, and of course we had to talk a little bit about glaucoma because they sort of go hand in hand. And I think a lot of the points that you want to keep in your mind is one, that sort of workflow we were talking about. So the big thing is to get your full glaucoma workup quickly. You don't want to lose your patients to follow-up. Sometimes psychologically, if you tell a patient to come back in 6 months, it sort of seems like, oh, it's not a big deal, and they might not come back until their yearly follow-up. So I like to see them back pretty soon within that 6-week follow-up. And again, like we talked about, until you have the data, until you have that follow-up, you don't know is the patient low risk or high risk. So you really need to have all your information. Always take a step back and make sure you're dealing with glaucoma and not another optic neuropathy like we had with the bitemporal hemianopsia patient. And of course, you determine glaucoma risk based on testing. So you need your OCT of the nerve and the macula. You need your visual field, gonio, PAX, IOP. Of course, you're always looking at the optic nerve head. Age is important, and family history is going to be important for some of our patients as well. I think it's very important to get multiple visual fields. There's just an inherent variability in visual fields. Patients a lot of times don't like doing visual fields, but I always explain to them just how important it is that we have to repeat it. So up until they get through that learning curve, you might not have such good data. So keep repeating it.
Yeah, I think we've talked about this just the other day, in terms of, some of the reports from Quigley or another paper from Weinreb, both of those docs, they do like to get, within the first 18 months, they do like to get at least 4 or 5 visual fields. So I think that within that first 18 months or the first 24 months, so the first 1.5 to 2 years, I think it's actually worthwhile to get at least 4 to 5 visual fields. The other thing, I don't know what your thoughts are on this, is that, sometimes what I tend to do is I may switch my testing protocol so that I may, tend to do something like a 24-2C early or CETA, faster, just so they get maybe a feel for clicking the button. And then if I need, to dive in a little more, if I need more robust data, then I do switch back to either CETA fast or a CETA standard. So, it depends. In most cases, I do tend to do CETA standards, but, you kind of gauge your patient.
For me, I actually use CETA faster a lot.
Mm-hmm.
Since having the new upgrade to the Humphrey visual field, I've been using CETA faster and 24-2C on all my patients. So
Yeah.
sort of the standard protocol.
Yeah, I think
I
it's good for
haven't
initial.
found that there's more variability. I haven't found that it's significantly different than my previous 24-2 fast or standard patients, at least for now. Again, I don't have 10, 30 years of data on it,
Right.
but maybe for the 6 months that I've been working through, it's been pretty similar. So I've been sticking with that. And it lets me just do more visual fields on my patients. So I think I might take a hit on the CETA standard versus CETA fast variability. So you have a little bit more variability, but I'll have more visual fields done in general. So I'll take the hit in one way to just have a bigger quantity of visual fields in general.
Yeah. And I think that's one of the papers from Crab where he looked at comparing CETA fast as compared to CETA standard, and if you have more visual fields, that variability decreases, and the difference between a CETA fast or CETA standard, you kind of lose that difference, so that a CETA fast is just as good as long as you have good longitudinal data.
With our glaucoma patients, our glaucoma suspects, we're not doing just snapshots. We're following these patients for years at a time. So at some point, quantity really takes over in these patients. You never want to miss these fast progressors. That's another reason to do a lot of visual fields in the first 2 years, because it's about 4%, maybe 5% of patients, they progress very quickly, so more than 1 decibel per year.
Yeah.
And like we spoke about, 1 decibel per year, in 10 years, you go from no visual field defects to pretty significant loss, which can start affecting your quality of vision.
Sure.
The big thing is, of course, use this data to determine your follow-up and your need for treatment based on risk. Get multiple IOP readings before starting treatment. Ideally, I'd like to get 3. Sometimes if you have a patient with definite glaucoma, 30 pressures on 2 visits, I'm probably going to start treatment on that 2nd visit. I'm not going to wait for a 3rd visit.
Sure.
But if someone has more borderline pressures, very early glaucoma, I'll usually wait for a 3rd IOP just to get that for the patient, so I have a better idea of what their Tmax and just average IOP is. Thank you all for being here with us.